My name's Sandy Steingard, and I'm a psychiatrist in the U.S. in a very soggy Vermont, though I'm in a dry spot. And I'll be one of the facilitators today. It's nice to see you all. I'll turn it over now to Cindy. Let me just say before I do that, I'll give you a sense of the overall structure. We have 4 speakers. Cindy will be introducing them. They'll each talk for between 15 and 25 minutes talking about their experiences. Then afterwards, Cindy and I will come back on for some reflection with the panelists. And then after that, we're going to allow people who want to join in a conversation to be on screen and offer reflections or comments. And hopefully we'll have some time for questions. So thank you. It's great to see you all here, and I'll turn it over to Cindy.
Thank you. Thank you, Leah and Sandy. I'm Cindy Peterson-Dana. I'm thrilled to be here today with everybody, with the partnership of ISPS and everybody that's here. I really want to personally thank our 4 panelists for taking the time to share about all of their vision, efforts, challenges, successes in bringing dialogic approaches from theory to practice in the UK and the US. So that's what I'm excited to be a part of going forward. I remember first hearing about open dialogue back in 2010 in the US at an event in Stockbridge, Massachusetts. And I was kind of immediately intrigued by the idea of meeting with individuals and families, listening to all voices, including service users in all decisions. And also noticing that they were having the best outcomes, or some of the best outcomes internationally. So many years later, I had the opportunity to train actually through the Institute of Dialogic Practice. Justin and I were both in the same class in the US. And also part of that training, I had the privilege of spending time in the UK and learning from Dr. Russell Razak, who's here with us, and also with Yasmin Ishak, who's also part of the panel. And so now I'm working as a dialogic therapist and trainer in the US and really hoping to bring this forward. I do want to mention that in addition to many, many decades working professionally in community-based nonprofit mental health, I also draw from my own lived experience. And I really see that as such an important part of this approach. First, I draw from, being a peer, dating back to my teenage years and finding myself in our mental health system, pretty heavy in the system, and finding my way through and beyond and into this field. More recently, in 2014, I experienced this work as a mom. And I am going to say being a mom of somebody going through what we may call an extreme experience was, or for some people may call psychosis, was by far the most humbling and the deepest learning that I've experienced so far in my life. So with one of my sons, who was 19 at the time, we were able to use a dialogic approach and navigate our way through with the help of a therapist and psychiatrist who were familiar with this approach. And I really want to say that it's not a quick fix, but it works. 9 years later, things have really continued to move forward in a very hopeful way. So I now want to briefly introduce the first of our 4 panelists, Dr. Russell Razak. Dr. Razak works as a consultant psychiatrist for NELFT, and I looked that up this morning, Northeast London Foundation Trust. He is also an associate medical director and director of research and innovation. Additionally, he currently serves as an elected member of the Council of the Royal College of Psychiatrists, and he's a visiting professor at London South Bank University. His particular field of clinical and research interest is mindfulness, which he's been a trainer in for over 15 years, and open dialogue. He's currently leading a national initiative to bring open dialogue to the National Health Service in the UK and helping to coordinate an NIHR-funded, multi-centered, randomized controlled trial, I believe the largest in the world. He has also published numerous papers, a book in this area in recent years. and many papers in peer-reviewed journals. So with that, I want to turn it over to Russell and welcome him. Thank you.
Thanks very much, Cindy, and thank you for inviting me today. I guess I haven't got any slides, so I'll just give an overview, a kind of description of the story really in Open Dialogue in the UK, and how we started to implement it and evaluate it. And this started about 10 years ago, so it's not a bad time to do this now. Roughly about 10 years ago, we started about 2013. We had a conversation in my own organization. I started to talk to folks at sort of board level in my own organization about Open Dialogue. And it appeared to me, that's when I first became associate medical director. So I'd been a senior psychiatrist for many years, but that was the first time I got into management and started to talk to people in the board of our organization. And it became clear to me that I've been interested in Open Dialogue for many years before that. And before that, I'd been a mindfulness trainer. So there was a obvious sort of graduation for me from learning to use mindful techniques for myself to actually spreading that way of working and being to others. So I started to talk to my board about it, and they were interested mainly for the reason that they realized their current system isn't working. And this is actually quite widespread understanding. I now work at national level in the UK, and it's quite, understood really that our system sort of has a lot of problems. We have a big kind of indoor, it's a public health system, so it's not too difficult to get referred into it. It's very hard to get out of it at the other end, because people end up remaining in the system very long term for very many cases. And so because of that, there was an openness to explore something new, do an experiment on a very different way of working. And so I managed to convince my trust to potentially start looking into Open Dialogue. At the same time, there were organizations and clinicians, colleagues around the country who were also interested. So I managed to sort of have conversations with folks around the country about potentially coming together for collaboration. Then started working with the Finns, met up with Jaakko and others about how can we deliver a training that's only 1 year, because a 3-year training, which was standard at that time in Finland, wasn't going to be something we would be able to deliver on a large scale within the UK public health system. But a 1-year training might be possible as a foundation, just basic level of understanding of Open Dialogue. Would that be possible? Took a lot of debating and a lot of very helpful, active engagement with Jaakko and other colleagues who then came into the UK and started to deliver the training with us. So we got an agreement. We started the first training in 2014. And it was the first training in the UK and NHS-wide. And we managed to get several trusts from across the country, Nottingham, Kent, my own trust in North East London, and a couple of others to come together for that training. It proved to be very popular. The staff had gone on a real journey. I added things like mindfulness into there, and we added a lot of personal development work, because I know that's really what makes the difference. Being able to work dialogically is really about being able to be present with yourself first. And if you can do that, can you do that with others? So we put a lot of that into the training. People gained a lot from it. They felt that it really transformed them as personally as well as professionally, and so it became quite popular. So we had other people then come in future years, and we've run the training every year since then, and we've trained about 600 people so far, mainly from the UK, but actually we've had folks from around the world, like Cindy mentioned as well. We had a large contingent from Holland at one point, and other countries too. And so as we began to sort of train, we always recommended training teams. So our goal was really to train folks who were actually coming together with their whole team, because we see that it's very difficult if you just learn Open Dialogue with yourself, go back to a normal team, then it's very hard to actually implement anything different. And it can become quite dispiriting, really, deflating after all of that effort and all of that transformation in yourself. Then you go back to your own service and it's not really changing. So we recommended bringing teams on board. As I said, the Finns continue to train us, to train others, and to train alongside us too, which is a very helpful process. What then we started to realize is we need to evaluate these new teams beginning to operate differently. And so I started basically to go and hunt for academics to try and find who we can get together to form a panel of academics to then try and get a proper study done. And I eventually found my way to Steve Pilling's office, who was the still is the sort of lead mental health academic in the country right now. He basically writes the NICE guidelines for the which is our kind of treatment guidelines in the UK. And to my surprise, he was actually instantly interested. He told me that that's what they had tried to do when they established home treatment teams. In the UK, we have these teams that try to keep people out of hospital by going into their houses and sending people in sometimes multiple times a day to support people. But the problem he had identified, and which I had known for some time, is that they basically become medication delivery services. They became medication focused again. And he was lamenting with me the fact that they never intended that. They always intended it for staff to work systemically, because they thought for the first time when you go into people's houses, you'll work with their families. And then he asked me, why did that not happen? I said, well, you never trained staff. And the thing is, often the thing you need to start doing is to not take the path of least resistance. You have to open yourself up to more emotional distress by inviting more people into the room. And unless you train people, A, how to do that, and B, the benefit of that, people end up trying to avoid it. So they just go in and out quickly, which is what happened. So he was very interested in the idea and asked if he could be the chief investigator for the trial, which I was more than happy to do. He then became the chief investigator of the trial. I'm sort of the clinical lead for the trial. And together we then recruited a whole panel of academics, 5 or 6 professors from various colleges and universities in London, and also other parts of the country, Birmingham, Oxford, and other areas. And we then put together a pretty audacious bid for a grant application of about £2.4 million at the time. For this, which was very audacious, given that there hadn't actually been any studies into open dialogue in the UK before that. So to go straight for that level grant was pretty daring of us. And we didn't expect that we'd necessarily get it. But and actually, we thought we hadn't, because the deadline for hearing back had passed. So we assumed we hadn't got it. It was about to pass. We were about 3 days away from the deadline, so we assumed we weren't getting it. Steve then called up the National Institute of Health Research that funds these studies, to whom we applied, and said, look, I assume we haven't got the grant. It'd be good to get some feedback. And they said, no, you have. I mean, we sent you the email, check your junk mail. And so he checked his junk mail, and there it was, the £2.5 million waiting. And with the message that if you don't respond to us by the next end of the week, then we'll assume we don't want it. But thankfully, he got to it in time. We got the grant. We started the study. Kent was a team who had already been running before, so they already did a little bit of data collection and published a paper on that, which is available now in public. Then we came together and we did the first 2 pilots, the Kent team and my own team in Northeast London, to try to demonstrate that open dialogue can be delivered to a decent degree of fidelity within the NHS system in the UK, which we were able to demonstrate. Then we brought all the other teams online, which was Islington in really inner London, sort of Camden, Islington, which is very, very inner London, Haringey, also inner London. We then had 2 teams in my own organisation, one in Waltham Forest, one in Havering. Then we got Kent, and then we got Devon. So we got a nice spread from relatively rural to very, very inner city. So different demographics across the board, different kinds of services. And it's called a cluster randomized trial, which means that we sort of delineated certain geographies within each sort of area that had sort of roughly the same sort of mobilities and populations. And then the clinical trials unit, which is based at King's College, then did a randomization, and they kind of decided how which ones will be open dialogue, which ones will be treatment as usual. So that way we have a control group that sort of decided completely randomly. This was the problem that everyone presented to me about the finished data, which is that none of it was randomized. So although it was spectacular in what they found, people kept coming. Whenever I went to policymakers, they kept coming back and saying, yeah, but it wasn't randomized. So how do we know it wasn't because of a change in the weather or the water or something? That's how academics think. So that's when we set about doing a properly randomized controlled trial, which this is. We started recruiting subjects from across the country. We set ourselves an extremely ambitious target of recruiting 500 people into the study, which is very large for a mental health trial. Actually, the NIHR gave us a bit more money to hit that 500 target, which is what they were hoping we would do. One of the things early on is that we started to bring in peer support workers from the beginning. I see Emma's there. Hi, Emma, mentioned that. And that's one of the things that we copied from outside Finland, actually. They never had peer workers in the Finnish Open Dialogue service, but they did in the parachute service in the States, which we then learnt from. I met some of the people involved in that, and that seemed like an obvious fit for us, particularly where we got populations where people might not have very big networks. Peer workers can make a big difference in supporting people, and also training and working as dialogical practitioners. So we kind of christened it Peer Supported Open Dialogue. We insisted that every team in the training and in the trial has peer workers within the team. Ideally, the more the better, but for some of these organizations, they'd never had peer workers before. So we said you at least need one in order to bring them into the culture of the team and the way it works. So that then continued, and to this day, we have peer workers in all the teams. Now, as I say, we had this ambitious target of about 500. Then the pandemic hit in 2019. And so we had to stop recruiting, and there was an edict nationally that all studies unrelated to COVID had to stop at that point. And I'm director of research for my part of the country, and that meant that a lot of trials actually went under at that point because we couldn't furlough researchers. So we continued to spend the money of the trial, but without recruiting any subjects. So when the lockdown ended, a whole lot of trials at that point realized they couldn't continue. Now we then went back to the Open Dialogue teams, which were relatively small teams, and we asked them if they're able to continue. Many of the staff had actually been re-provided to acute parts of the system and come back again, and every single one of them said enthusiastically, yes, we want to continue, we want to prove this, this is kind of our life's work, we want to really demonstrate this. This is the degree of passion that the teams had demonstrated. And so we resumed recruitment, and just about 18 months ago, or sort of just a little bit more than 18 months ago, we completed recruitment. We recruited all 500 subjects from both groups, the control group and the Open Dialogue group. So that was a bit of a milestone for us. And then we have 2 years of follow-up to follow that up. One thing that we've noticed as this trial has gone along is that you generally don't announce findings from a study before the study is complete. But there's one finding that we're already announcing because it's so obvious. That is that staff retention is way higher in the Open Dialogue service than in the Treatment as Usual service. So, for example, where I work, since 2017, we've had 100% turnover of staff. In other words, there's nobody there in the team at the moment who was in the team in 2017. That's in the control group. But in the Open Dialogue group, we've only had about 10-15% of staff change. And that's only because it's a small team. In order to get promoted to a higher level, they've got to go to a different team. Otherwise, they would have stayed. So that's a 5 times higher a retention rate. So it's 500% higher retention rate in Open Dialogue than Treatment as Usual. And that same picture has happened in every single pilot team. So we know that one of the things the study will find is that the staff stay in their teams, they're retained in their jobs a lot more when they work relationally, they do Open Dialogue, than in any other kind of way of working. And that's a bit of a holy grail for the NHS, because after the pandemic, 2020 saw the largest exodus of staff from the National Health Service in the UK in its history. Almost certainly because of the trauma of the pandemic people had gone through, but staff stayed in the Open Dialogue services, and the NHS is looking everywhere in terms of how we can keep staff. So that's a major finding. The rest of the findings we can't say, because the control group, I don't know, I haven't met them, and usually we're separated, it's blinded, so we don't know the difference, and we won't know. There are some hints from some of the sites, they think that there's a significant difference they'll notice, but we've got to wait. In October is when we finish the 2-year follow-up. We were measuring things like, do people end up bouncing back into treatment more often if they have had Open Dialogue or not? We want to show that actually there's more time between episodes, there's less relapses, less often people are coming into hospital, less often people are coming back to services when they have Open Dialogue compared to Treatment as Usual. Those are the things we're looking at. And when the follow-up, 2-year follow-up, while we measure all of this, it ends in October this year, then the statisticians will do their work, do all the number crunching, and we expect to have the first data sort of early, sort of springish next year, and then it'll be submitted to journals, which will then be where it gets published and when it becomes public. So maybe sort of spring, summertime next year is when we'll know officially what the actual outcomes and the data is. So we're all waiting for that. But in the meantime, a number of the organizations involved in the trial are already deciding to invest heavily in Open Dialogue. There are parts of the UK that are talking very excitedly about it. And even if there was no such thing as Open Dialogue, policy. I'm now involved in I'm sort of national strategic and clinical director of a body called the National Collaborating Centre on Mental Health, and we advise NHS England. So I'm kind of involved in policy these days. And the direction of travel is very much towards dialogical care. Not that it exists on the ground, but it's very, apart from in the open dialogue pilot teams, that's where policymakers want us to go. There's been a series of scandals in sort of national documentaries around inpatient care in psychiatric settings that have caused a lot of consternation amongst government and ministers. And so there's a lot of push now towards moving in this direction. And so, as I've said to a number of chief executives in the last couple of weeks alone, even if open dialogue didn't exist, this is what we'd have to do anyway, even if there was no trial. So some trusts are actually looking to buy into it in a big way already. Certainly in London, there's trusts investing in a large way. So things are moving in a positive direction. Let's see where Odessa goes. But I've got a lot of hope that we have now built up a level of expertise within the country, a level of knowledge and understanding of working dialogically, that if we're able to, and if the policymakers allow us to, we'll be able to spread it in a large way over the next couple of years. We have an election in the UK next year. We want this to be on the agenda, and we're hoping that all of this will culminate in a significant change in the end. We can't promise or assure or know the future. We have to tolerate uncertainty, but I think there's a lot of good reasons for hope. So I'll end there. And yeah, happy to jump back later for questions and things.
Thank you, Russell. Thank you so much. So we're really looking forward to having a panel discussion with all of you once everybody's finished their presentation. So our next panelist is Tony Munoz-Hilliard. He's a certified peer specialist, also nationally certified peer specialist, who firmly believes in the power of lived experience. So this resonates close to my heart. Tony has used the challenges he's navigated in his own life to inspire hope in others and illustrate that recovery and whole health wellness are indeed possible, in spite of mental illness, substance use, and our difficult life circumstances. And I know in the peer world, there's many different terms that we use for those things. Tony has lived experience with major depressive disorder and substance use, and uses his training specifically in intentional peer support and also the need-adapted treatment model to support and provide trauma-informed care to peers. Need-adapted treatment was actually a precursor to open dialogue and was used in the parachute model in New York City. Tony has also worked on a mobile treatment team in New York City and is an advisor for the Public Psychiatry Fellowship of New York State Psychiatric Institute that's part of Columbia University Medical Center. He's presented nationally and internationally on topics such as peers on interdisciplinary teams, the peer workforce, trauma, and social determinants of health. Tony's currently a student at the State University Empire State College in New York, where he is pursuing a bachelor's degree in psychology. He's also a trained video producer with Manhattan Neighborhood Network, which allows him to incorporate the arts in his recovery process. Tony also enjoys biking, movies, theater, painting, photography, and travel, and is fluent in English, Spanish, and French. Welcome, Tony.
Thank you, Cindy. Thank you, Cindy and ISPS for having me. And thank you, Russell, that your intro really resonated, and I've made some points to make sure that I speak about during my conversation here with everybody. So as Cindy said, I came into need adapted treatment model, open dialogue through the parachute program back in 2016. I was a member of the Department of Health Consumer Advisory Board at the time that parachute came about. So I was able to get on board, first starting with the respite centers part of parachute. The model was, having a respite component and then having the outreach community portion of parachute. So or everybody was trained. We were trained on the need adapted treatment model and intentional peer support, which I think worked very well together, right, in this holistic polyphony of voices, where everybody, was able to hear each other, the families and the identified individual were able to have these conversations, so that they can come up with their own solutions and own way of moving through crisis into having the lives that they wanted to have. I really believe in open dialogue and intentional peer support in the way that allows for dialogic practices. I think it's important, right? Even just for myself to be, I think it changed the way that I relate to my network, even at work. I think it was very important in having these types of relationships where I hold no answers for anybody but myself. I just think that this was a very different way of working, right? Being a Mexican American and not understanding what mental illness, what how to talk about these things, right? And I think these two models were able to help me, have conversations differently with providers and the individuals that we were working with. It was certainly something that I really believe in what was happening, and I saw, right, people moving towards their life and whatever they wanted, holding that space. I remember as part of the program, right, we would go into the inpatient units during discharge and be a part of that process and having those discussions with the inpatient treatment teams and the family, and talking about parachute and how things would work. And sometimes these conversations were very, I think, difficult to have, right? Because sometimes it was, this is what you have to do. This is, you have to take these medications. You don't talk about your voices. So being part of this team, going in there and saying, oh no, but we do talk about what's going on. We do talk about the voices. We do talk about medications and how they make us feel or not, or what's not working. So just being able to have those conversations and having everybody just stop to think, I guess, for a minute, that there was something different and a new way of dialoguing with everybody, right? Because this didn't just affect the individual; it affected also the family network. There is, one thing that I always like to talk about, and that's just from my own experience, right? For me, not knowing social determinants and how they affect the way that I take care of myself, or the way that I see myself, how childhood adverse events affect affected me throughout my lifespan as far as taking care of me and taking care of myself and looking to the providers to take care of or to help me understand these things. And I think with open dialogue and working on these teams that allowed us to open up different conversations, right? People sometimes didn't understand what was going on, using reflections to do all this. The intentional peer support component, I just think that helped the relationships between the individual and the team, just to have somebody that could sometimes, be a part of the conversation, and knowing that they have somebody that understands, right, when maybe they're not being heard or understood. So that was important. I presented in Peru. I just came back from the Czech Republic presenting on peers and dialogical practices out there. One of the things that is dear to me is always talking about the whiteness of open dialogue, right? I don't see anybody that reflects, who I am. And sometimes in working with these individuals, especially here in New York, with such diverse individuals that we come into contact, that was important, to understand things culturally, to understand things through a different language. So that's one of the things that I'm always talking about when I come into these meetings and these spaces of dialogic practices is, why doesn't it reflect me or some of the other individuals that we work with and families that we work with. I wish we could have open dialogue teams here in New York. Unfortunately, once Parachute shuttered, it's one of the things that I asked Jaco when I was in Czech was, I was under the impression that open dialogue was working and providing, teamwork out there, but I come to understand that it's very individualized. A lot of people are doing individual work, and even for myself, it's hard to do this on my own when there's nobody else to hold these spaces for people, right? So, but I try and use my knowledge from open dialogue, intentional peer, to continue to work with individuals. Yeah, sometimes it's difficult. Sometimes it's, I don't know if the word is frustrating, but it definitely, I think, works better in teams. I wish it wasn't as expensive as a model to bring into practice all over, because I really believe, just the experience of working on Parachute, right? Going from an intensive treatment to moving through people going into their lives, right? Doing what they want to do. We had people reaching back out saying, "Hey, I'm doing great. Just wanted to let you know, that's great, right? As far as my own recovery, that's always great to be able to go back to individuals and say, "Hey, I'm doing okay, I'm taking care of myself, or, you know, I'm struggling with this and I need additional support, or, you know, I just need to talk about things. You know, doing peer support. You know, Cindy introduced me to this other peer support network of peer support that, you know, we continue to meet and you know, share our hopes, dreams, and you know, what life is all about. So that's my open dialogue experience. Thank you.
Thank you, Tony. Thank you for being here. So I'm going to introduce our next panelist, Justin Palanci. Dr. Justin Palanci is an assistant professor in the Department of Psychiatry and Behavioral Sciences at the Emory University School of Medicine. He serves as medical director for the Assertive Community Treatment Program at Grady Memorial Hospital. His interests include recovery-oriented care for persons experiencing serious mental illness, racial disparities in the assessment and treatment of psychosis, and the relationship between trauma and psychosis. Dr. Palanci is certified as a dialogic practitioner and trainer through the Institute for Dialogic Practice. Welcome, Justin.
Thank you, Cindy. And I want to first start by saying thank you so much to ISPS for inviting me to be a part of today's event, and how humbling it is truly to follow both Russell and Tony, both of whom have had big impacts on me. And so to be part of this group and to follow the two of them is really special for me. Bear with me as I pull up some slides to help guide my comments. I hope that's okay. So I'm going to talk about my experiences with bringing these ideas and this way of working to Atlanta and to my treatment context at Grady Memorial Hospital. I have no disclosures. So very briefly, I'm going to talk a little bit about my own background and give some context around the Grady Memorial Hospital system and the services that we provided leading to the development of our program, our project called Open Dialogue Atlanta, how that project evolved in a couple different ways, and then a couple key takeaways that I think are sort of broader points that I wanted to make as part of my comments today. So just briefly, I started my residency in psychiatry in the July of 2015, and started working on our psychiatric inpatient unit in 2016, where quite quickly I recognized the importance and the value of engaging families in the treatment of the folks that I was working with, which wasn't part of the culture on the inpatient unit that I worked. I was really fortunate to have a colleague who was a discharge planner on the unit, and she and I sort of paired up. This is before we knew anything about open dialogue, and kind of we became known as the family meeting team. And those family meetings weren't quite the way I think they would be now with my training in open dialogue, but I still think it was an important precursor. And really, those efforts and that work led to Dr. Rob Cotes and Keith Wood, when they were bringing this project on open dialogue to Grady, to invite me into that process. And I think the key point from this slide I wanted to make is that I'm incredibly fortunate that I was introduced to these ideas so early on in my training, before some of the ideas and beliefs crystallized in a way that maybe it would be more difficult for me to sort of shift my ideas. I also had the great fortune to, as Cindy mentioned, be a classmate of hers at the Institute for Dialogic Practice, where we completed 3 years of training from Mary Olson and her team, which was a completely formative experience for me. Had the opportunity to work as co-director of Open Dialogue Atlanta when I joined faculty in 2019. And I've also been serving as the medical director of our Grady ACT program since that time. Just a little bit about Grady Memorial Hospital. For those who are unaware, so Grady is a safety net hospital system in the Atlanta area. From a psychiatric services perspective, there are inpatient, outpatient, and emergency services. The outpatient clinic serves more than 7,000 unique clients per year, and a majority of those individuals identify as African American, and about a third of them have been diagnosed with some spectrum of a psychotic disorder. The outpatient services include a general outpatient clinic, a clozapine clinic, which was started by Dr. Cotes and co-directed by another colleague of mine, Dr. Goldsmith. We have our ACT program, and then in recent years, we have a coordinated specialty care program, Project Arrow, which I'll be speaking a little bit more about in a few minutes. So briefly, just the history of the idea. Prior to having a coordinated specialty care program, there was really a major gap in services for persons experiencing early psychosis in our system, and the engagement with those individuals left a lot to be desired. It was very poor follow-up rates with outpatient care, which I think reflected in part people's experience with the care they received in crisis and inpatient services. There was also a major gap, really no culture around engaging families throughout the system. And so both of these felt like really important opportunities when the idea of bringing an open dialogue project to Grady was brought to Drs. Cotes and Wood. We were also a control site for RAISE, and so looking at coordinated specialty care, so it was an opportunity to try something new. So in 2016, a team that consisted of Mary Olson, Doug Zidonis, and Eileen Small helped us implement through an organizational change model and this project that we ended up calling Open Dialogue Atlanta. That consisted initially of 3 on-site trainings from the group. We put together a clinical team that consisted of psychiatrists, licensed professional counselors, psychologists, and a research staff. So I was obviously one of those psychiatrists. Began working, meeting weekly as in team meetings, in which we had case consultation and fidelity assessments with that oversight team, and then we had in-house supervision, which we eventually shifted into, inspired by Russell and his book, into shifting into more of an intervision mode in terms of our team meetings. We had both clinical and research components, and this is really important to us because for very understandable reasons, a lot of the people that we work with are hesitant to engage in a research study of any kind. We still wanted to make this clinical work available to folks. And so we worked with many more people than in a clinical way than engage in the research study, which I'll talk a little bit about in a moment. And over the course of the 5 years of the program, worked with over 100 networks, and we were quite a small staff. So I think that was, I think we were able to reach quite a few people, and these were some of the funders for that project. It was primarily grant funded, which we can talk a little bit about the financial piece if folks are interested later on. So what did the clinical services look like briefly? So it focused on a systematic engagement of social supports in the treatment process, inviting families in the room from the get-go as early on in the experience of working with individuals as possible. This, in our context, this looked primarily like network meetings taking place in our outpatient clinic. Although we were able to provide some limited services in the community. And then we did provide continuity, working alongside inpatient teams. So the open dialogue team sort of functioned as a system within a system, where from like the intake process, the way it worked in the clinic, through the treatment, and then if folks were in the hospital working alongside the inpatient team, if folks were meeting with a case manager that was, housed in the sort of general outpatient clinic, inviting that case manager into the network meeting as appropriate, et cetera. As I said, we also had a research study that looked at the feasibility of implementing an open dialogue inspired approach into our setting. It was modeled in part after the Advocate study that was led by Chris Gordon. Some of you may be familiar with. Participants were between the ages of 18 and 35, had experienced psychosis within the last month, and were willing to have at least one support person involved in their care. And we evaluated domains of feasibility, including implementation, adaptation, practicality, acceptability, and limited efficacy. This is the first of what will hopefully be a few papers that will come out about our experience with this approach. This came out this spring, and in the interest of time, I won't be able to go through it nuts and bolts, but I encourage folks to check it out and welcome your feedback. I did want to highlight one piece. So it was a mixed method study. So we had both some quantitative outcomes that we were looking at and also qualitative findings. And I just wanted to share a few comments that came out of our qualitative analysis that I think hopefully reflect the broader experience that those 100+ networks had working in this program. So when people were asked about sort of how they thought about themselves from a diagnostic perspective, there was a shift where they said, well, I was told I have some diagnosis, or I was told I'm depressed, to things more like things weren't going my way, or I'm in between emotions right now, more personally relevant ways of maybe perhaps sort of seeing the nature of their troubles. Folks feeling that in sort of traditional care, they felt more poked and prodded, whereas within the open dialogue team, they felt that the clinicians involved were genuinely concerned and really paying attention. And that also this way of working served as almost a way of modeling for folks, or as a resource for folks in their own lives outside of the treatment setting, where they talked about how they would now do, quote, sidebars at home, or if there was a circumstance, a discussion with a family member or something to talk about, they would quote do an open dialogue, which I kind of love that phrasing, and again, I think hopefully speaks to people's experiences with our project. So when we looked back on this program from a success, looking at successes and challenges, we felt this was feasible with relatively brief training, and really sort of on the job training, if you will. So we had those 3 initial trainings, and then that ongoing supervision, intervision, and fidelity assessments that helped us grow and mature in our ways of using this approach over time. The organizational change process was key, I think, to the success of the project, and there was some context-specific adaptations that needed to be made. For instance, not going into the community as often as perhaps would be done in other settings. We were able to routinely utilize network meetings, incorporating dialogic practice, bringing families into the work, doing a much better job of tolerating uncertainty, and helping to bridge gaps between inpatient and outpatient services. And it was felt that there was really a cultural shift to a more person-centered way of working. But there were challenges as well, and in part because we were working with some of our group were trainees, and almost everyone was working part-time in this project. There was staff turnover, and sort of engaging people in training and keeping people up to date in terms of training was a challenge. Again, I already mentioned sort of meetings being largely limited to in-clinic. The other piece of this is we sort of had this open dialogue team, and we were doing dialogic-based work and network meetings. But when there was a need would arise for other forms of services, individual therapy, case management, substance use disorder treatment, for example, those weren't built into the open dialogue treatment team, and so folks we had to interface with more traditional based services, which would prevent a challenge, and of course the financial sustainability was also a challenge. And ultimately, from the Open Dialogue Atlanta project, when the grant funding ran out, we sort of shifted in the way we were working, but this specific project came to an end, and that was in 2021. So as we approached that time, we were thinking about, well, what are next steps? How do we build off the strengths of these experiences and address some of the challenges? And it just so happened that at that time, Dr. Cotes was approached by the state to start a coordinated specialty care program. And learning more about that way of working and thinking maybe there would be an opportunity to integrate the two approaches. Excuse me for one moment. So very briefly, I'm sure most of the folks here are aware, but coordinated specialty care is an early intervention program, somewhat based on ACT services, but it's a multidisciplinary team that works both in the clinic and out in the community to provide, client-centered care, and involves things like case management and therapy and nursing, supported employment, peer support, which is absolutely invaluable and was not a part of our original Open Dialogue Atlanta project, and then a family peer support member as well. And so in the summer of 2019, we launched Project Arrow, which stood for Achieving Recovery Through Resilience, Optimism, and Wellness, as sort of a hybrid open dialogue coordinated specialty care team. And it was a big ask. The team was trained kind of in sequence. It was a new team. Some of the members of the Open Dialogue Atlanta team shifted into this project. Others were brand new, and they were asked to learn about coordinated specialty care and implement a coordinated specialty care program from the get-go, and also learn about this thing called open dialogue and implement that into the work as well. So that primarily looked like utilizing network meetings to engage patients and their families, from the start, and use this sort of open dialogue frame for engaging families in a way where I think that the emphasis in coordinated specialty care is a bit more on psychoeducation. Not that that's necessarily a bad thing, but it's just a shift in the way families are sort of brought into the treatment setting. We are right now working on a manuscript where we are looking at the qualitative perspectives of the professionals involved in the development of Project Arrow, and sort of the meeting of these two ways of working, open dialogue and coordinated specialty care. And there's also a mixed method study of the intervention itself that we are working on. So, where does that sort of leave open dialogue at Grady right now? I am also incorporating this way of working and engaging families and engaging the people with whom, sort of identified patients in a dialogic way, albeit in a much less formal way than is happening in Project Arrow. We have started providing in-house trainings to both some ACT staff and also Project Arrow staff for a refresher or for new staff. And hopefully this will be something that I'm doing in collaboration with Sylvia Browning, who's now a manager within our ACT program and is also a graduate of the Institute for Dialogic Practice, and trying to find ways to broaden our reach within the department and within the services, so people can utilize these skills that they develop and some of the values that open dialogue instills in the way they're working. And I also have to say it's had an enormous impact on my role as an educator, the way I approach teaching trainees, and I think that's been a huge. I hope it's been a huge benefit. I feel like it's been a huge benefit from my perspective. So that's a bit about my experience in Atlanta. I wanted to share sort of two broader points that I think are really important. I really appreciate Tony for speaking to this in his comments as well. So, epistemic injustice is a concept that I became familiar with about a couple of years ago now. And just very briefly, it's this idea that people are not seen as credible witnesses to their own experiences due to a bias or stereotype on the part of the listener. And so this can occur in as a part of racism, as a part of sexism, as a consequence of someone being labeled with a mental illness or having a mental health diagnosis. And as I mentioned at the start, the population that I serve here at Grady are a majority, a group of people who have faced various forms of trauma, oppression, marginalization, minoritization, both within the mental health system and outside of the mental health system. And that is something that I try to be very mindful about as a white male doctor. And as I try to navigate this. And this way of working, I think, has helped create a space. It must come with intentionality, but it has helped to create a space in which people can speak to these experiences if they are moved to do so, and in a way in which they can feel validated. Perhaps it's a space for some processing and opportunities for some meaning making, but also opportunities to say that you should not have been treated that way, or it's not right that you had that experience, and that if that is contributing to some of the distress or quote unquote symptoms that you're having now, like, we need to think about this in a broader way beyond sort of the biomedical perspective. And humbly, I would say that, I've been able to have some of these conversations with people, and I think I know it's had an impact. And so I appreciate Tony speaking to the whiteness of open dialogue. And I think that we really have to be intentional about pursuing matters of social injustice, epistemic injustice. I think this work, or this way of working, can be a pathway for that if we do it with intention. So thank you for allowing me to share those comments. I have one other broader point that I want to make. And I've heard both from Russell and Tony, and I certainly understand it as someone who was given the great opportunity to go and do the intensive 3-year training, and it's expensive and it's time consuming. And, I was the only person in the cohort that was able to make that work to start. And we've had a couple others join since then. But, and I think it's, definitely, obviously, by definition, open dialogue is a team-based approach. And I know there are significant systemic barriers to implementing open dialogue more broadly in the United States. But I also want to say, and that can be discouraging, and it's discouraging for me sometimes, but I also want to say that that developing the skills and fostering the values that open dialogue does, dialogic practice does, has made a huge impact on me as an individual, both in my personal and professional life. And I feel strongly that has had an impact on the individuals I serve, whether it happens in proper open dialogue network meetings with reflections and with, sort of being as true to open dialogue and the principles of open dialogue as I can in my setting, or when it is, I'm one-on-one with an individual and, not working in a space where it's sort of proper open dialogue, but still being able to create a space where meaning making can happen, where something unsaid can be said because there's a space, something yet to be said can be said because there was a space created. And so, I encourage you all that, if you're interested in this way of working, if it piques your interest, to really think about, that I want the system to change. I want to be a part of that system change. And it's something that I advocate within my own system. But also you can have a huge impact on an individual level. And I'm a starfish guy, which is why I threw this photo up there. And I do feel strongly that this way of working has had allowed me to have a bigger impact, a more positive impact on people's lives than if I had not had this training and not had these experiences. The last thing I'll say about that is that I think the team can come in various forms. And I think what ISPS is doing and sort of leading in terms of creating a program and creating more space to talk about this work and for people to share about their work is really part of that I am sustained by learning about what Tony is doing and what others, and what Cindy is doing, what other, what Yasmin and Russell are doing. And that is sustaining for me. So anyway, it's a pleasure. And I just want to say thank you. And this is a picture of some of our original team from circa 2018. So thank you all again for your attention.
Thank you, Justin. Thank you for everything. So many things I could comment on, but I'm going to now move on and introduce Yasmin Ishak, who is our fourth panelist today. I met Yasmin back in 2017, I think at an ISPS International event. And I was really drawn to her work, and especially the way she brought in people, those of us with lived experience, as family, as peers, and that became a big inspiration, and we've become friends since. So I feel very honored to introduce her. So Yasmin Ishak is a social worker and psychotherapist in the United Kingdom, public sector, and she's worked there for over 35 years. In addition to the peer-supported open dialogue training, Yasmin undertook the 2-year trainer's course in dialogic practice in Helsinki, 2016 to 2018. She's worked in statutory mental health services in the UK for over 28 years and has been in management roles for the last 19 years. She's been at the forefront of developing new initiatives and started up the early intervention in psychosis service in East Kent in 2005 and the primary mental health social work service in 2015. From 2016 to 2021, Yasmin led the first standalone open dialogue service in the UK and evidenced that the approach could be developed, sustained, and provide positive outcomes for individuals and families assessing specialist mental health services. Yasmin currently provides training in open dialogue and consultancy support to organizations developing their dialogic practice. And hopefully that'll include ISPS-US. She also has a psychotherapy practice and offered clinical relational supervision to statutory and voluntary sector services. Welcome, Yasmin.
Oh, thank you, Cindy. That was a long introduction, and thank you to ISPS in the United States for inviting me here, and also to my fellow panelists. And I had mixed feelings about being last in this, but I suppose lots of feelings were stirred up as I was listening to the other panelists, and they may weave their way into the story that I'm going to tell. So I'm just going to share my screen and my presentation, and I've got a few slides to share. So I think as Cindy was saying, that she gave my professional background, but I also want to share that I'm a mother, a daughter, a sister, a friend, alongside being a social worker and a trainer and a psychotherapist. And in all the years that I've worked, probably the quote, which is why I have it in most of my slides, that really encapsulates my way of working is the Maya Angelou quote, is, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And that's kind of almost been an internal mantra for me all my probably personal and professional life. Okay, so just going to think about how did I come to be with you here today? And there's always a story behind why we come to places, why I've come to this place today to be alongside you all. And also, again, as the other speakers were thinking, my internal dialogue was continuing about what do I share about myself? What do I share about myself that enables others to hear and feel my presence? And that changed as I was listening to the inspiration of the other speakers before me, and also the reconnection with Cindy. And it doesn't feel like years since I had a personal contact with Cindy, but it kind of sits within me. And also, from a person who's quite shy and in my earlier years was never a public speaker, to think that actually I've got to a place where I've found a voice, and I've had to work hard to keep my voice at times, particularly during this dialogical journey that I've been on, because it's not always been easy. And I'll share some of those challenges, but I also see challenges as opportunities as well, and I will talk about that as I go on. I want to start with the personal. So my introduction to mental health care was in October 1987, well before I trained as a social worker and well before I moved into the field of mental health. And it started with a crisis in my family. And it was a crisis that had been developing for my brother in my family, who was really struggling. And I won't go into details, but he was really struggling with life. And in October 1987, for those people old enough probably now, there was a great storm in London, in England, and there was a lot of damage caused. People call it the Great Storm of 1987. There's not been a storm like it since then. And my brother was struggling at that point, and he was in my mother's house. And as the storm gathered apace, a tree fell on the house, not damaging the house significantly. It just kind of leaned over and was sitting on the house. That was the trigger for my brother, who had been in a space where the outside world had become a very, very unsafe place for him. And the only safe place, and this is a bit of my interpretation, was my mother's house. And suddenly that was at risk and that was in danger. He then became very, very distressed. And as a family, we didn't know what to do. We had absolutely no idea how to manage his distress or the extreme state that he had got into. So we did reach out for help. And I'll just tell a little bit of the story that these people came to our house. I can't remember who they were. The only thing I remember them saying is, you need to take your brother to hospital. And the picture here is the hospital that I took him to, which was an old originally a Victorian asylum, but it was called Claybury Hospital on the outskirts of East London. And I took him there on the night of the storm. And it had this long driveway. And as we were driving up this driveway through these very wrought iron gates, and I remember the wrought iron gates and the very high brick walls, which said to me, this place keeps people in here and keeps other people out there. And that's the message I got. And growing up, everybody knew about Claybury Hospital. But not many of us had been inside Claybury Hospital. And here I was taking my brother in, driving up this driveway in this storm with the trees swaying, and my brother in the back of my car looking at me in the mirror and whispering, "Don't leave me, Yasmin, don't leave me, don't leave me, don't leave me." And me thinking, I don't know what to do. I have to follow what the professionals are telling me to do. So I took him into the hospital, and I remember going onto the ward. And I remember being there for 2 hours and nobody spoke to us. Nobody asked us how we were. Nobody wanted our views of what we thought was happening to my brother. Just after 2 hours, I think it was a nurse came out and said, "You can go now," to me and my mother. And so we left him there. No words of, "It's okay, we'll take care of your brother now, don't worry." We just left. And I think we left hoping that maybe they would be able to help him in a way at that point that we couldn't as a family. But that, and I tell this story because that left an indelible mark on me in terms of how professionals work with families and how organizations work with families. Because when my brother had his crisis, we all had the crisis. It wasn't just my brother having the crisis. I liken it to a hand grenade being thrown into our family. And all of us were hit with the shrapnel from the hand grenade to varying degrees. And really, I think it went on for years in terms of what we knew, what we didn't know. In fact, more what we didn't know. I just know that my brother came out of hospital on a load of medication, and I didn't know why he was on this medication, but professionals were telling us he needed to have this medication. So we saw our role as ensuring that he complied with his treatment, which I think is not an unfamiliar story for families, and the dilemma that often families can have when mental health services are telling them this treatment is what the person needs, and sometimes the person doesn't want that treatment. But as families, we're being told, part of your role as a family is to ensure they comply with their treatment. So I just wanted to leave that with you, and that's a little bit about me and my story and what led me to really start to think about where I could work, which was more family orientated, and it took a while. So just my professional story, and I think as Cindy said, I qualified as a social worker in 1989, so a couple of years after my brother's crisis. And I worked as a probation officer for 6 years. In those days, you had to be a social worker to be a probation officer. So, and what I did is I really developed my relational skills as a probation officer. I was working with some very difficult, some very damaged, some very distressed people. And I think I really developed over those 6 years very good relational skills and an ability to be curious and wonder what had happened to people, what had brought them before the courts. And when the courts asked us for reports, which they did regularly, I thought my story was to really give a narrative of what had happened in that person's story and that person's history that might have contributed to them coming before a magistrate or a judge. So even from the early days, I was curious about people's stories, and how what had happened to them influenced their behaviour. So in 1996, I decided I needed to move into mental health services because I was meeting so many people who were so distressed, but felt that my knowledge around mental health was not where it needed to be. So I made a move into mental health services. And I remember the first week I moved into a mental health social work team thinking, I've developed really good skills, I should fit in here really well. And I recall the language that was being used by my social work colleagues, and I didn't understand it. I did not understand what they were talking about. They were talking a medical language that I had no understanding of. And it really challenged me, because I thought, actually, surely the best way of helping people is that we create space for them to be able to talk, for them to be able to share what's happening to them. And all my colleagues were saying at that time was, this person needs this medication, they need this kind of treatment, or they need this level of hospitalization or restrictions. And I would say I struggled initially. I really struggled, but I decided I needed to persevere. Even though my skills, my relational skills, I felt had been demoted in the scheme of things. And also my belief of what I could bring as a social worker had also been demoted in the hierarchy of the mental health system. But I wasn't willing to give up, and I did want to carry on trying. And I continued in the work. But I always wanted to do things differently. So as Cindy spoke about, eventually I got to start an early intervention psychosis service in Kent. And what excited me about that is what I read about the model is that it had a strong social perspective, but also being family inclusive. So I thought, I want to do this, and I want to, and also that my brother had what had been labelled as a psychotic depression. So understanding psychosis more, it was something of a personal motivation as well. And I think we did well in terms of working with families and starting initiatives of doing some family work. Again, the family work was still about professionals educating the family rather than a collaboration between professionals and families to work out what's going to be helpful. But it was a start. It was a start of working with families and hoping that by working alongside families, there might be better outcomes than maybe I had experienced on a personal level with my family. So the search continued, and although I loved managing the early intervention service, it was still very much led by a biomedical understanding of psychosis. And the whole reason that in the UK that more money was given to early intervention psychosis services is that it was seen as a disease, and it was seen as only if you intervene early do you get the better outcomes, and early intervention meant medication. So it was still very biomedically driven, even though we were trying to bring in more social and family aspects into the work. So I was gaining satisfaction, but not complete satisfaction from the way of working, because there were still things that I felt were privileged, understandings that were privileged above other understandings. So I continued my search. Okay, so I think that Cindy and Russell had mentioned that my work is in Kent, and Kent is on the southeast coast of the UK, the closest county to France, and we worked in Canterbury in terms of the open dialogue service. That's where it started. So I just wanted to locate that. So quite close to London, but probably from where I worked, we were closer to France than London. Okay. So Cindy mentioned the start of some of my journey, but a bit like Russell, it started around 2011 when I went to a conference, and I think it was an ISPS conference in England, and I heard Jaakko Sikula talk about the work they had done in Finland and in Tornio. And I remember feeling quite excited by what I was hearing. And my bodily experience was that I felt my heart rate increase. And I thought, oh, this is really affecting me on an emotional level, what he's saying and the work they're doing. So I then pursued it for a few years, and I went to a number of workshops and tried to increase my knowledge and understanding of what had happened in Finland, and really started to think, is this a way that we could work in the UK? And then it was 2013-14 that obviously I came into contact with Russell and other like-minded people. And as Russell has said, that we came together for a training program. And although I was finishing my training as a psychotherapist, that training was really quite transformational for me. And a lot of that transformation was the self-work, was the work we did on ourselves to understand ourselves. And I really attuned to what Russell had said is, we need to be able to be with ourselves and understand ourselves before being alongside others. And somehow in the way that we develop people professionally, regardless of what profession that is, sometimes we move away from that. And this training brought us back to who we are as human beings, regardless of whether we were a social worker, a psychiatrist, or a nurse. Is what is it to be human, and what is it to be in relation to another human being? Doesn't exclude your knowledge or your experience or your expertise, but it is about connecting on that human level. So in Kent, we had a couple of years of training, a couple of cohorts, and then we were able to start a team in 2017, as Cindy had spoken about. And we wanted it to be a standalone team in Kent, and we got some extra money from the Health Foundation, who gave us some money to get a standalone team off the ground. As far as possible, we wanted to try to replicate the kind of fidelity of the model as much as we could. And we felt that if we could do that as a standalone team, we might have the opportunity to see what the outcomes were locally, as well as contributing to the national Odessi trial, and understand if people experience a benefit from this way of working. And I will talk about the research paper that Russell mentioned earlier a bit later on. Since then, I left the team in 2021, and now I primarily am involved in training in open dialogue, but also crucially alongside that, and I'm doing this at the moment in central northwest London, is being part of a practice development team. So bringing my knowledge and experience to assist other organisations, not only with their training, but then how they are developing in practice, because there is a leap between training and bringing into practice something which is really quite different. And although a lot of people say, well, that's what we do anyway, it really is fundamentally different in terms of understanding distress and how we are alongside people and allowing people to have the opportunity to have a dialogue about what's happened and being inclusive of that person's network, whether that's family or friends or others, and that it's a collaboration. And yes, we have a knowledge that we bring to the table, but it does not make us the expert of what's happening. The expert of what's happening is the individual and often the family. And we are visitors into that space alongside them to try and understand what's happening and to see if there's anything that we may be able to offer that could be supportive. So that the training and the implementation are two parts of the same process, and they're very important. That, and I think Russell had said it, that people can get very disheartened if they do the training and then they go back to their organisations and they don't have an opportunity to practice or develop that way of being, because people lose that, or they leave, or they go somewhere else where they've got open dialogue. And just to add what Russell said about staff retention, which we experienced, but also as the manager, I had the responsibility of oversight of the sickness rates in the service. And year on year for 5 years, we had the lowest sickness rates in Kent. And Kent is a very large county. So we were a team of 10 and Kent employed 4,000 people. So there's actually something in the way of working which I felt was healthy, not only for the people we were working with, but for staff and for colleagues as well. And although that's not been researched, and although I'm thinking of that in terms of the raw data, there is something about the way of working that allows staff to be able to share sometimes their worries and their vulnerabilities in a supportive environment where there is curiosity and support rather than labelling. This is the paper that we published last year. And like Russell was saying, we wanted to do a small study in Kent to see if we could implement peer-supported open dialogue in the National Health Service. We obviously were delayed as well because of COVID, but we were also delayed because our researcher, Marcus Coleman, who's credited here, died during the phase of pulling all our information together and pulling the report or the paper together. And when I reflect back on it, it became very painful to go back to trying to write that paper for a while. And I would say it probably took us maybe a year to 18 months before we could, for me, I can't speak for others, but for me, could overcome the pain of losing Marcus and coming together and writing this paper. But in the end, being driven to want to write this paper in honour of Marcus and all the work he did in terms of being our researcher. And this paper is freely available. It's open access. So if you just put the title in, it will come up. Just a little bit about the measures that we use. So these are standard measures that are used in the UK to measure mental well-being and carer well-being, etc. So I'm not going to spend too much time because I know we're probably tight on time. But what we found is that overall people's well-being improved. But not only the individual's well-being improved on a social and well-being level, but also the carers and families found it really supportive in definitely in the first 3 months, feeling supported, feeling heard. And I think following the dialogical principles of that first network meeting, of having everybody who knows or is concerned about that person, who the person's wants present, we really actively worked very hard to ensure that we had that engagement We didn't always get engagement, I think, as has been spoken about before. Sometimes we work with individuals, but even if we work with individuals, we brought in the voices of people that they would speak about, maybe family members, and we would ask them what would their family members say if they were present. But really from that first meeting where we were looking to use the strength and agency of the individual and the family to help us understand what's happening. And really we go into these meetings in a completely not known position. And we never presume to know anything. And that's really important, that we don't go in with assumptions, maybe based on somebody else's lens, maybe based on the general practitioner's lens or somebody else's lens who's seen this person before they come into our service. But actually, we genuinely go in a not known position and create that space for people to be able to speak about what has happened, and having no agenda. And we had to learn to go in and have no notepads, and that just be all really, really present to what was being said and what was being shared. Okay. Just a little bit, and this kind of, in a way, echoes a bit of what happened in Finland when we talk about bed days. That we found, just looking at the raw data between us and the locality teams who worked alongside us in Canterbury, is that we use far less bed days. So the mean average of bed days for a peer-supported open dialogue person was 0.44 per year, compared to our crisis team and community mental health team services, which was 2.24 beds per day. So we were having an impact on bed occupancy as well and inpatient care. There's something about where we met people, how we supported people, and also that principle at the end of every meeting is saying to, when would you like to meet again? It might be the next day, it might be the following week, but we wanted to ensure that we would meet people whenever they wanted to be met, whenever they felt they needed support again, but also that there was also a continuity. So at least one or two of the people who were in that previous meeting were in the next meeting. So there's that continuity of care as well, and that continuity of relationship. And for me, the primacy of the relationship is what makes the difference the most in anything we do. It's about the relationship. Okay. And just if people haven't seen this guidance on community mental health services, a World Health Organization document, I think came out a couple of years ago now, but it did identify the crisis service in Tornio in Finland as a beacon of good practice. So that was recognising that open dialogue and dialogical ways of working were really beneficial to communities. A little bit about the transition for workers. So in a way, this way of working was against a tide of service development. So the service development where I was working was all about short-term interventions and transitioning between services. And we were coming and time limiting the level of interventions that everybody had. We were coming in with this service saying, we don't want those transitions. And we want the service to be there for as long as the person and their network needs us to be there. So no time limits. That was a bit freaky for some people in the organisation. But also that we wanted, that philosophical move was that move from that expert, individualistic, hierarchical way of working to a more flattened, and as I said before, the not knowing way of being with each other and individuals. And that, and in Kent, it was a challenge for a long time. So for a number of years, we were the only team. And although there were promises of expanding the way of working in Kent, it didn't happen. And then as happens sometimes, there's a change in leadership, and that can go one of two ways. The change of leadership can lead to, we don't want this open dialogue or dialogical practice anymore, or it can lead to, actually, we would like to expand this. And we were fortunate with the change of leadership about a year or so ago. They decided, actually, we now want to expand this again. We like what's happened in the Kent service. We like what's happened nationally with the Odessi trial with Russell. And actually, we want to invest now in developing this way of working further within the organisation. So what I would say is in the UK, possibly, and Russell might be able to comment more on this, is it's fits and starts. You know, you think you're gathering momentum and then it seems to slow down and maybe almost to a standstill, and then it gains momentum again. And I suppose the hope is that when we get the national trial results coming out next year, there will be a momentum that gathers again. That's the hope, anyway, the hope that I have. And just a little bit, I think, again, that Russell and others might have mentioned is the supervision and intervision and how important that is. And for me, it's very important because we are asking people in the service and practitioners in the service to be present, not only as their professional selves, but as emotional human beings connecting with other human beings. And that takes a lot of emotional energy. And therefore, as a team, we needed to have a space where we could be held, where we could share whatever we needed to share. So it was peer group supervision. One of the things we looked at, again, which has been mentioned earlier, is things around power differentials. So even within the team, there are power differentials with me as a manager, with others as a psychiatrist. So we look at the power differentials in the team, let alone the wider system we work in and the wider community we work in. When we had team development days after the training, we'd continue to do the self-work. We'd continue to do family of origin work or relational connection work, just to deepen our understanding of ourselves and of each other's. And also always looking at where do the boundaries lie in terms of how we share of ourselves and what is helpful to the people that we're working with and what's helpful for them to give back to us to help us work. So there's no hard and fast boundary, but it's always a constant topic of discussion. And when I was in the team, that supervision or intervision would take place on a weekly basis. And just as this is my last slide, really, that there has been some national recognition for the work that we did in Kent. The award that I'm holding was a Social Worker of the Year award for innovation and creativity. So I was very proud as a social worker there was some recognition of the work that I was doing leading that service. And then also at the Royal College of Psychiatrists in 2018, we won Team of the Year for the innovation and the work that we were doing in open dialogue. And I think that's it from me. So I'm going to stop sharing now.
Thank you, Yasmin. Thank you. So I think Sandy and I are going to take a couple minutes and reflect on the panel and then invite the panelists back for a brief dialogue, and then invite anybody here present today who wants to be part of the dialogue and turn their cameras on to raise your hand and let us know. So we're going to be working on that over the next 20 minutes. Sandy, would you like to start?
Well, I mean, that was I really enjoyed all the presentations. I think I've talked to or heard many of the people present before, but it was very moving and inspiring, the work they're doing. I'm mindful that there's a lot of people here. You know, we talk about hierarchy and giving voice. I want to keep my comments brief because I think there are people that have comments, but you know, the highlights for me were resonating a lot with the journeys people have gone through and thinking, you know, my internal dialogue about my own journey and the notion of humility and feeling unhappy with the way services are, and then feeling driven to find a change, because I think it is a lot of work. I think Yasmin just talked about the up and down, you know, is necessary. So, you know, I found as a psychiatrist that humility was the only way to move forward given the problems in the field. So having a way to practice that's centered on humility and a less hierarchical approach just made sense to me. But I'm curious what your reflections are, Cindy.
And I also want to keep mine very brief, because I really think what I've come to value more than anything is listening in this approach. I heard a story recently that kind of human wisdom and experience could be looked at like a pie chart. And there's a very tiny slice that most of us understand. And then there's another little tiny slice that most of us know we don't understand. But there's such a huge part of the pie that we don't even understand, that we don't yet understand. And I'm always so moved in these dialogic spaces by how much I learn. And so I'm really leaning towards listening rather than a lot of comments. But the one thing I'm going to just mention is epistemic power. And I heard Yasmin say she had mixed feelings about going last. And I heard Tony speak to adversity and all the cultural privilege and injustice. And I heard, everybody speak to that one way or another. So that's my hope for this initiative as a community with ISPS, to really make this way of working more accessible through training, support, everything. So on that note, I want to invite the 4 panelists to join us. And then briefly, we're going to invite everybody who would like to as a participant. So please raise your hand if you want to join us in a few minutes. So if the panelists could just come on, and I'm curious what everybody's thoughts and reflections are.
I had this feeling of sort of filling up as everyone was sharing. And I think that image or that idea that Yasmin shared about sort of those ebbs and flows, the idea of momentum, the idea of the journey resonated most with me.
Mm-hmm. Mm-hmm.
Yeah, first, my appreciation to everybody. I think there's still this fear about, maybe being vulnerable and sharing experiences, and how we're seen, how we may be judged, how we might be negated. But I think, this model open dialogue, intentional peer support offers, us that opportunity of getting to untold stories, holding these spaces with everybody. I just, I keep talking about how much I love this way of working, because it's really enriched my own relationships, with personal relationships and with the people that I work. So I'm just grateful for everybody. Thank you.
Yeah, I'm just aware that people want time to be able to engage in dialogue at the end, and we don't have many minutes. So I think, perhaps open it up. But I won't say any more until we get questions in.
I think just one thing that's just come to mind for me, and I'll just share it briefly, is that even when I did the training, I was not totally convinced about how well it would work until I started working with individuals and their families. And they were the ones that convinced me that this was a better way of working, because of what they fed back to me. So I'm eternally grateful to particularly those early families who took a risk with us in engaging in a new way of being together, who convinced me that this was a good way of working.
Thank you. So I've seen Mark join us. Mark, if you want to share and turn on your camera if you'd like. And please join us if you'd like to be part of the dialogue.
Oh, were you addressing me? My screen
Yes.
cut out there when I switched. Okay, thanks for having me speak here. I actually wrote my question to keep it brief because I was so inspired by what was just said. So I have lived experience and I have gone through the multidisciplinary process or multidisciplinary team process and had one of the largest teams ever for a psychiatric case. I went on a hunger strike for political reasons, and I have found there's two suggestions. I'm curious what the panelists think Dialogic would do about what happened. So most people end up in the mental health system because I think of resistance to the current societal system or spiritual emergencies. And in my case, I wonder about breadth. So there was a problem with breadth in my multidisciplinary team where we had people on it, but they were already inside the system. So everybody felt afraid, like maybe Justin was saying, to make waves, even the clinical ethicist who was the philosopher on team. So I was wondering, do you guys think it would be a good idea to have activists, people who are outside the system resisting it, to also be on these teams? Because that might have helped my case. And then the second thing I'm wondering is for depth of these open dialogues. We can acknowledge spiritual experiences, but there doesn't seem to be an actual logical process to make it respectable in a scientific way, where modern science or psychiatric training can actually interface with it and respect it at a deeper level. And there are some models out there that we have found, and I'm not sure if you guys have found any models that can help that depth component of the open dialogue, but if you're interested, I would love to have that discussion. Thank you.
I think that the breadth question is a really good question, and I think something that this way of working opens up is that when you have your network meetings, it's whatever the person wants to bring, and also who they might want to bring into that space with them, and that can be anybody. It could be somebody who has a spiritual understanding of what's happening for the person, or something different. So I think it enables, and I think it relates to the thing that Justin was saying, is the network meetings are often the decision-making meetings, so where we collaboratively make those decisions about what's going to be helpful. And that doesn't necessarily sit within the mental health system. Often the helpfulness sits outside of the mental health system, and that's okay to incorporate into support. That's just my initial thoughts on that.
And Mark, thank you so much for your questions and comments. And I mean, I'm thinking about this idea of, inviting outsiders, activists in, and this is something that I very much struggle with, of sort of, if I want to impact change, do I do it sort of embedded within the system? Do I go outside of the system? How does that work? And I guess in these few moments thinking about this, I guess I'm reflecting on the idea of polyphony, and this idea that I can speak in many voices, and that maybe sometimes, maybe not often enough, I don't know, but maybe sometimes I'm speaking in my voice as an outsider or an activist who's, saying like, we have to change the way we're doing things. Things must be different. And then, but it's absolutely a dilemma for me. How do you go about bringing change? And so I just really appreciate you for raising that to the group.
Thank you. Thank you, Mark. So in the interest of time, Raji.
Hi, everyone, and great to see Justin here again. And thank you all for this one, and also Cindy, yes, for this wonderful, dialogue here. I mean, I'm going to say that, I am really sitting with, what everyone has shared, and especially Tony and Justin's comments about epistemic injustice. in a way, right, we're sort of really admiring and appreciating open dialogue. And at the same time, in a way, it's a rediscovery of what's deeply understood over the entirety of human history about relationality, about humans' loneliness. Dr. Vivek Murthy, the Surgeon General, talks about loneliness and as an epidemic. None of these are new inventions. They're rediscoveries about what's already known as human in many cultures and many religions and spiritual traditions and all of that. And so the idea is here that even if we lose our way as humans time and again, this is about, for me, I want to see it as I want to embrace this because it's familiar in a very deep way in helping me get in touch with what we already know as human beings. I'm hearing about examples in Finland and also this is even clinically, right? If you think about psychotherapy or various traditions, peer work, it's not about this is not known. It's about who has access to it and who doesn't. And I'm working with people who are cycling between jails and prisons and shelters and streets and homelessness and hospitals. So this is all well and good in a way. I don't want to sound, maybe it's okay for me to be skeptical, but not cynical. So I'm going to try hard with my tone. Is that, yes, maybe it works in Finland, maybe it works in UK, the way healthcare systems are set up. I don't know how healthcare is set up in Finland. And we can all congratulate each other about this progress that's being made. But the worst of healthcare is what my clients have access to. The worst of education, the worst of schooling, the worst of, welfare system. So how can we put our brilliant minds together to say, how is it that my clients in New York City are ever going to be able to access this? Because psychedelics has gone into private practice and academia. Everything gets privatized, academized, and it does not come to the people I serve. So I really want us to have a critical, please, let's have a critical answer, or at least start to begin to brainstorm about this.
So I can say a couple of things. I think you raised very important points there, Roger. I think that the NHS is struggling right now, and the UK, the National Health Service, we have real staff shortages. We have probably the highest waiting list in its history. We have some of the worst. It's probably in some of the worst conditions it's been in since it was founded. And so in the middle of this, trying to make change in this direction is a real challenge. And I guess there's two things that occurred to me while you were talking. One is that the first thing is that there is an international effort that we're engaged in at the moment called Hope and Dialogue. And what that is doing is basically looking at examples of open dialogue around the world. So the first thing they did is map the based in Italy, but they're mapping globally where different open dialogue services are. And there's some in every continent. There's 60 odd different services around the world. And then we're doing some research on looking at what the common areas are and using some common data sets to try to accumulate some research. So what we want to be able to do is to demonstrate, if things work out in our trial, in the Odessi trial, that it's not just working because it's here, or it didn't just work because it was Finland, but it's globally applicable. So we want to be able to show that through the Hope and Dialogue study, which is undergoing at the same time. So we're doing small evaluations around the world to complement the Odessi data. So it shouldn't be transferable. We hope to be able to show that. The other thing is that, absolutely, without doing full open dialogues, there's still a lot you can do to improve services. So in my policy making role, which I'm starting in gradually on a national level, that very much is what we want to demonstrate, that you can show people how to use reflective practice, how to do reflections with clients, but also in their team meetings. You can show people how to, the nothing about us without us philosophy, how to respond compassionately, how to keep an open space, how to make people feel safe, how to, give that people a sense that they are able to tell their story and their narrative, make sure people come away from meetings feeling heard, right? How we can train people to do that. So there's lots of permutations of trainings we can do to raise the standard, and that we'll call dialogical practice rather than open dialogue. So I think that there's a lot that can be done. I think there's a lot that we can take from that training, and I'm also experimenting with smaller versions that we can train teams or inpatient wards At the moment, I'm talking to sort of government about, potential for training 200 wards plus, and because there's real impetus now to make change. And how do you do that? How do you scale it to that level? So yeah, there are definitely ways to do it, and there's creative ways to do it. And I think it's very important that we keep exploring that. I'll be publishing some papers around this soon. Others will be. So we need to look at open dialogue as a sort of ideal and a 5-star service, which is probably not going to be everywhere. But what can we do also to enable other people to really benefit from these ways of working on a broader scale, nationally and internationally too? So there's lots of channels where I think more possibilities might emerge from this.
Thank you, Russell.
I'd also like to add, along with the, the setting up the practice, right? It goes into how we welcome the individuals that we're working with, right? And how we're talking about what's happening and how they're understanding what's happening to them, right? Or what has happened, their experiences, the systems that they've encountered through their journey into wellness, right? And helping them to understand, what are the things that are, that might impact their recovery or changing the way that they, that they want to be in their lives, right? I think it's important to help them to reconnect to their community, right? If we're in our community, we're more likely to stay in our community and look for those resources that are going to help us stay there, right? I certainly don't want to go back into a hospital setting, right? So if I'm able to, to have these conversations and like I said, understanding social determinants, ACEs, what are the, how did I learn to take care of myself this way? And, a lot of it for me was intergenerational, right? I grew up in this family that didn't take care of themselves. So how do I change that? And that's by knowing what systems I'm coming up against and looking into my community so that I can reach out to them and help them to help me stay well and in my community.
Thank you, Tony.
Thank you. And I'm just really realizing how tight we are for time, given how rich everything that's been touched on is. Any last, I know that I have one more announcement before we finish, but any last thoughts or comments?
Can I make a quick question and thought? We don't have to explore it now. I'm from Connecticut. We've been also trying to develop peer support, peer-run respites, and I'm wondering, just thinking out loud, could a peer-run respite be a good place to consider starting an open dialogue program that could then be continued after the person has left the place? I'd love to talk to people more about that.
Yeah. So I'm going to jump in with a response. Did anybody else want to respond first?
As part of Parachute, we were trained in open dialogue and intentional peer support. I just don't know what, if that's continued practice now or not, but yeah, I think it was, beneficial to have open dialogue, right, in the relationships and working with individuals. I can recall an instance where, me and this other person connected on our experiences on suicide, right, and having those conversations, without judgment. And it's not an easy subject, but at the time we could laugh about our experiences with suicide, and I think open dialogue helps, bring these voices together, right? So that we can talk. And sometimes we're not allowed to talk, especially we're in a system that says, oh, we need to admit you into the hospital because these are things that you're sharing.
So I know we're out of time. I want to thank everybody for being here. I did have one quick comment in response. Early in my training, I was told I was very attracted to the idea of peer-supported open dialogue, or including lived experience that Russell and Yasmin and Parachute, Tony, were part of. But I was told that this is a clinical approach. It's not a peer approach. And I kind of continue to be curious, like, what did that mean? Where did that thought come from? I don't have an answer to that. So I just want to share that, I think back to Raji's comment about being cynical, because I also wish for shared voices. And I really love the spirit of our space today in that way. I want to mention that Leah, the executive director, asked me to share some last comments about ISPS-US and what we're hoping to do. We're really hoping to create a dialogic collaborative community where ISPS-US is part of it, but each of us are part of it who want to be involved. So I want to just invite anybody interested to join us as we try to figure out how to make everything accessible relating to dialogue, training, support, invite everybody into the dialogue. People that we haven't even thought to invite, I think, are definitely important to intentionally think about. And we will be starting this 18-hour course. If anybody's at all interested, please, it's an introductory course. It's kind of an experiment, but again, we're going to have a sliding scale and really hoping that it will be an opportunity for anybody interested to join our dialogue. And that will start September 16th. So just wanted to mention that for Leah. And again, thank you for being part of this. Thank you to the panelists. Thank you to the participants, everybody who made comments. And this is all recorded for, I think people can get transcripts if they weren't able to be with us today, or if you'd like to look at it afterwards. So thank you again. Take care.